Good afternoon or good morning, everyone. My name is Fran Phillips. I'm a former Senior Deputy with the Maryland Department of Health and Mental Hygiene. I'm currently consulting with the Health Systems Transformation Team here at ASTHO, the Association of State and Territorial Health Officials. I'd like to welcome you to today's Delivery and Payment Reform Technical Assistance Call entitled Leveraging Innovations in Health Information Technology to Advance Public Health. ASTHO, with funding from the CDC, launched this technical assistance call series in January 2015. The purpose of the calls was to focus on some of the key areas that states have identified for additional assistance as they move forward with payment and delivery reform. The 4-part technical call series consists of 90-minute calls with substantial time set aside for open discussion with the audience, that's you, so that you get your questions addressed and have an interactive discussion with the presenters. Participants also have the opportunity to submit questions prior to each call. Today's call is the 4th in the call series, and as I said, we'll be highlighting opportunities for public health in leveraging health information technology innovation. So let's turn to our first slide, which, as you can see, presents the 3 objectives for today's webinar. Briefly, first, the discussion will highlight examples of how advancements in health information technology, that is HIT, whether those advancements result from SIM grants or otherwise, may be leveraged for public health purposes. Secondly, we will discuss the challenges which public health agencies face in accessing and interpreting new data sets. And thirdly, the discussion will identify population health gains to be derived from applying new health information technology to advance public health. So before proceeding with the webinar, we'd like to quickly pose 2 basic questions to you, our audience. As you know, the subject of HIT is a vast one with many, many different levels of familiarity and experience. In order to orient our speakers in presenting their material, it would be helpful if you can respond right now to the 2 questions. You'll see 2 sets of slides appearing on your screen. The aggregate results of each question will be collated immediately and posted. So let's take a moment and respond. Here you can see the first polling question, which asks you to identify your organization. So if you check the appropriate box there and go ahead and submit it, then we'll wait a minute and we'll get a sense of our audience participants today. So the returns are still coming in from precincts, but as you can see, we've got a good cross-section of folks on the slide, largely state public health, but also local public health agencies. And I can see that you've now advanced to the next question, which is whether or not you work directly in informatics. And looks like about 2/3 of you do have direct informatics experience in your work, and 1/3 do not. So that's I think that'll be very helpful. So thank you for taking that quick survey. Before our speakers begin, then, I'd like to share a bit of background as a basic level setting prior to the presentations. As this first slide indicates, a couple of key definitions to the terms that we'll be using repeatedly during the discussion. That's both health information technology as well as health informatics. You can see these are just 2 selected definitions of many that are out there. The definition for HIT comes from the National Center for Health Legislators, and the health informatics definition comes from the great state of Louisiana, the Louisiana Center for Health Informatics. Next slide, please. So here's a bit of history that probably is worth recalling for those of us like myself who did not live and breathe with the beginning, the legislative, or the federal level, the legislative beginning of HIT, derived from the HITECH Act of 2009. And back at that time, and clearly continues today, HIT was seen as a powerful engine for economic growth. The ARA Act, as you will recall, intended to stimulate the nation's economy and included the high-tech provisions which we are familiar with today. So health information technology is absolutely essential to health reform, that is, to transforming healthcare delivery and financing to improving quality, efficiency, and community health. The HITECH Act set forth a national technology and information foundation, which has indeed proven essential to implementing the provisions of the subsequent Affordable Care Act. Next slide. This slide shows 3 steps, kind of the building blocks and the progression of HIT infrastructure as it has been evolving. Moving from digitalizing data at the individual clinical site to more purposeful bilateral communication of that data to population-wide data exchange for clinical and other purposes. The term meaningful use, as you see on the slide, is for those of us in public health and in the entire health sector, of course, meaningful use has become a household term. It refers to the incentive program operated by HHS's Office of the National Coordinator for Health Information Technology, that's known as ONC. ONC links an estimated $30 billion in incentive payments for demonstrations of meaningful use of various applications of HIT. Next slide. So meaningful use, as you probably know, has 3 progressive steps, moving from initial digitalization of information to disease management, clinical decision support, medication management, support for patients' access to their health information, transitions in care, quality measurement and research, and lastly, and very importantly, communication with public health agencies. This slide shows examples of public health communications which are captured in meaningful use stages 1 and 2. We'll leave stage 3, meaningful use stage 3, to our presenters. Next slide. So I'll conclude this really brief introduction to the development and importance of emerging health IT with this slide, which represents 5, I guess, no, more than 5, half dozen examples that are drawn from my own recent experience with population health initiatives which have been greatly boosted by access to big data or to health information technology. So by that I mean working with aggregated electronic clinical records via health information exchanges. There are tremendous opportunities to advance specific public health challenges. So this list is just meant to illustrate a few examples, a few possibilities, and no doubt each of you has encountered equally meaningful examples. What I've got here as far as the 6 that I personally have experience with includes geo-mapping, surveillance information for preparedness purposes, communication of post-discharge hospital information or clinical information to support warm handoffs or transitions to community providers. Certainly the clinical support for prescribers with prescription drug monitoring programs, prescribers of scheduled medications, and tapping into health information exchanges for that purpose. Interestingly, we've used health information exchange data to evaluate certificate of need proposals and other regulatory activities around providers' utilization. And then lastly, looking at outcomes and effectiveness research for specific health conditions. So those are just some of my experiences, and I know that as I said, many of you have many, many other examples. And while there really do remain major unresolved issues and barriers, we know that, to accessing health information technology from public health agencies, it's really clear that the enormous power of HIT is one that's very significant in advancing population health. So with that, let's turn to our 2 expert speakers. First, we will hear from Jim Daniel for the national perspective, followed by Joe Foxhood for his presentation at the state level. And what I'm going to give you here is our very, very abbreviated backgrounds for 2 people whose experience in HIT and public health is both very deep and wide-ranging. Jim Daniel, MPH, has been the public health coordinator for ONC since 2011. Previously, Jim was the Chief Information Officer for the Massachusetts Department of Public Health, where he also worked as an infectious disease epidemiologist and director of informatics. Joe Foxhood has more than 25 years of experience in data and technology strategy, infrastructure, and design in the private sector as well as in public health agencies. Within the Louisiana Department of Health and Hospitals, Joe heads the Center for Population Health Informatics. He has served on the steering committee for the ASTHO Public Health Community Platform and represents the Office of Public Health on the State HIT Advisory Board. So here's how we'll organize the presentations. After Jim presents, there will be time for a few questions before we move on to Joe's presentation. And the operator at that time will provide instructions for asking a question via the audio line, or alternatively, you may submit your written questions anytime in the chat box. And following Joe's talk, there will be ample time for more questions for Joe or both speakers. And we will also pick up some of the questions that have been submitted prior to this call. So with that, I will turn the call over to Jim Daniel. Jim?
Great, thanks. Can you hear me okay?
Absolutely.
Okay, and can you just remind me about what time I should aim for our question, the initial question period to be over?
We're thinking about 25 minutes.
Okay, super.
If that will work for you.
Okay, thank you. All right, so we're going to talk about a couple of different things today, both what's in the current proposed rule for Stage 3. I know we just heard a little bit about what was in Stage 1 and Stage 2 for meaningful use. But then I think I want to spend some time talking about some things that are a little bit more exciting, what I like to call beyond meaningful use in public health. So we can go on to our first slide. So just to start us all off and to level set, there is actually a notice of proposed rulemaking out right now. The comment period closed last month, and that is for the Stage 3 Meaningful Use Program. And Stage 3 is a little different from the previous stages in that it really seeks to align all of the stages of meaningful use into one single stage. So moving forward, starting in 2018 as required and 2017 as optional, all of the providers are really going to be in the same stage of meaningful use. They're all going to meet the new requirements set forth in Stage 3. Between now and then the rest of 2015, 2016, and 2017, there's another notice of proposed rulemaking out from CMS called the Modification Rule that seeks to make the remaining years of meaningful use align with Stage 3 as well. But again, it's really trying to get all the providers on the same timeline, same time frame. And in a way, it makes things easier for public health. There were a lot of differences between Stage 1, Stage 2, and the proposed Stage 3 measures. So it actually helps public health as well because there won't be different processes that public health will have to support. Next slide. So on the CMS rule side, there are only 8 objectives. One of the main goals of the new CMS rule was simplification. So it's much simpler, much fewer requirements. So there are currently only 8 objectives. And you'll see objective number 8 is public health and clinical data registry reporting. Next slide. So within the public health objective, I think a lot of people get concerned because there is only one objective. But within that objective, there are actually 6 measures. And the proposal here is that the providers must be in active engagement to submit data to public health, except where prohibited by law, within these 6 measures. Eligible professionals must meet 3 measures, and the hospitals must meet 4 measures. Next slide. So along with the CMS rule is a new ONC rule for 2015 edition certified technology. So we have decoupled the rules so that this 2015 certified technology rule can be applicable to other programs besides the Meaningful Use Incentive Program. There is a new definition for base EHR product, and it's been redefined in a way where there are no optional or required criteria. The developers can choose the criteria that are relevant to their purpose. Next slide. And the ONC rule actually calls out the standards for all of the public health measures as well. So I think some of these will look familiar to you. Some of them are actually new. So Measure 1, immunization registry reporting, has actually been in there for both Stage 1 and Stage 2. There is a new component of it that's part of the new standard or the new implementation guide that calls for bidirectionality of messaging. So not only do the providers submit their electronic immunization records to the state, they also must be able to receive a full history and a forecast back from the IIS. So that's a really new and exciting component of what's in the NPRM on both the CMS side and the ONC side. It's called out in both the CMS rule, the bidirectionality component, and also within the standard and certification on the ONC rule. Measure 2 is syndromic surveillance, which is probably familiar for everyone as well. The standard here references what hospitals and urgent care facilities should be sending to public health departments. There was not a standard reference for how ambulatory providers would send that data, as it was recognized that not that many states are actually accepting ambulatory data at this time. Measure 3 is a really exciting new measure that is part of the NPRM for electronic case reporting. So this is a concept where providers are submitting the clinical data that goes along with the lab data that a lab has submitted. Electronic lab reporting has been in there previously, but often providers need some additional information that they're not always getting from the lab, and providers might not always fill out the paper case reports that they're required to. So this is around getting some of that additional clinical information around reportable cases to public health. Measure 4 is a more general objective around public health registry reporting. It includes the measures a measure that was in there previously for reporting to cancer registries, along with 2 new ways to meet this measure, which are reporting antibiotic utilization and resistance data to NHSN at a national level, and also reporting national healthcare survey data at a national level to NCHS. So those are 2 measures that are new, and they're different in the respect that the reporting goes directly to CDC, not to the state. Measure 5 is also a new measure in Stage 3 around clinical data registry reporting. This is an acknowledgement that some reporting for the good of population health might not always be to a public health agency, but there might be nonprofits or specialized disease registries set up that providers may want to report to as well. And then Measure 6 is electronic lab reporting, which is the hospitals reporting the reportable and notifiable conditions to the appropriate public health jurisdiction. That was in there for Stage 1 and Stage 2 as well. So as I said, eligible professionals have to pick 3 of these. Eligible hospitals have to pick 4. One caveat is that Measure 4 and Measure 5, since there could be multiple opportunities within those 2 measures, could actually count more than once towards meeting that overall objective. So that's kind of the summary of where we are with our Notice of Proposed Rulemaking on both the CMS side and the ONC side. And as I said, the comment period has closed for all of those, and all the federal agencies are working hard to get a final rule out. Next slide. So now I want to go into what I think is the more exciting part of the talk, and where we start thinking about the interactions between public health and electronic health records and the health IT developers in a way that's really looking forward, and what we do moving into the future, with Stage 3 meaningful use and beyond that as well. So one of the things that the public health community decided to do, and this was very much at the recommendation and suggestion of the public health community, was to align its work with the Standards and Interoperability Framework. So the Standards and Interoperability Framework is an ONC initiative where new standards are developed to meet specific business cases. And what we realized in the public health community is that a lot of the standards and initiatives across the S&I framework seem to have public health uses as well. So originally the public health community had started by joining all of these individual S&I initiatives, as we call them. And we had a suggestion from some folks in the public health community to develop a team that looked across all of the S&I initiatives with a focus on where public health intersects with them. So we developed within the S&I framework a group that we called the Public Health Tiger Team with a specific focus on looking across all of the S&I initiatives, deciding where there could be public health use cases, and doing the communication between the Public Health Tiger Team and those individual S&I initiatives. Next slide. So we found that there were 3 basic S&I initiatives where public health seemed to play a major role, or where there were lots of public health use cases that could potentially be met within those standards. So the first S&I initiative that I'll talk about is Data Access Framework. And Data Access Framework is all about making the data within an electronic health record open and available through standards. And for those of you who are more technical on the call, that's open and available through APIs. So there are lots of different use cases within Data Access Framework where an organization might want to access its own data to write its own report on to make a recall list of patients with diabetes who have A1Cs over a certain level who haven't been seen within the last 6 months, just to make a recall list to call those patients in. Currently, you might have to go through your vendor to generate a simple report like that. The idea with Data Access Framework is that those data would be open and available in a way that you could write that report yourself or hire your own contractor to write that report, as opposed to having to work with the vendor who developed your product. The second use case is you might want to be querying across organizations. And I think this is one that was brought up in the introductory slides, where if a patient were to show up at an ED, that emergency department might want to query the primary care physician for simple information like current med list and current problem list and allergies. Again, the standards here that make the data and the EHR open available would allow that organization to query across to another organization about that individual. The final use case in Data Access Framework is the one that really applies to public health, which is querying across multiple provider organizations to get an aggregate view. So this is something that I think was really put forward by the ACO community, where they might want to develop practice-based models looking at different providers within a practice to get reports within an organization aggregated. But the same use case could also be applied to public health, where public health could really query across organizations and get information at the community level. Next slide. So Data Access Framework is a series of standards that talks about how data is moved from one place to another, what the security is, and how you actually structure your question. So in the case of public health, in use case 3, there would be a very specific way that you asked across the community, tell me everyone who has a diabetes diagnosis with an A1C value over a certain level, and then aggregate that information by geography, sex, and race. That might be more what public health is interested in than what's going on at a particular practice site. But that query structure would allow for them to ask that question across multiple providers. And then there's also a standard for the results coming back in, and then the data model to support those queries, so that public health can ask this same question to multiple provider organizations and pull that information together and aggregate it to get a community view. Next slide. So there are some basic data elements that go into that data model that we're talking about. I don't think any of these should be a surprise to folks. The physical exams, encounters, allergies, those sorts of information would all be in the data standards for data access framework. And some of you may have heard this called as query health in some of the pilots as well. Next slide. So there, as I said, some of the pilots were called query health, and there's some really exciting pilots going on both in New York City and Massachusetts that I wanted to just touch on briefly. Next slide. In New York City, they have a model mainly working with the primary care information project, those providers that are connected directly through the New York City Department of Health. So here it was a little easier to develop a pilot because there were already some connections to these providers through a hub that they had built. Next slide. So through that infrastructure, they had 751 practices covering over 2.5 million patients, and they were able to look at things around population health, chronic disease, and infectious disease outbreaks. Next slide. And just to kind of give you some idea of some of the things that they were doing, just to kind of think about how this data might be used, one of the things they started looking at was just obesity prevalence and figuring out how that might compare to other survey methods that they're currently using to get obesity data. They've also used it for looking at other chronic conditions, and they have some really great work coming out of that project over the next few months. Next slide. And in Massachusetts, they had another pilot project utilizing a similar infrastructure. And I should go back to the New York City model and mention that they're actually expanding beyond the providers and their primary care information network and connecting through the HIE to other providers. In Massachusetts, they have a slightly different model where they did not already have direct connections to providers, but are working with one large healthcare organization as well as with the network of federally qualified health centers. Next slide. So it's overseen by the Massachusetts Department of Public Health, was started with funding by ONC, and they're working with Atrius Health and the Massachusetts League of Community Health Centers, looking at over 1,000 physicians serving more than 1 million patients. Next slide. So as I said, their infrastructure is a little bit different, but still based on the same data access framework standards. Next slide. Some of the things they looked at were just influenza-like illness at an ambulatory level, looking at both visits and vaccinations. Next slide. And one of the other really interesting things that they did was look at gestational diabetes. And they were actually able to identify some areas of the state where gestational diabetes seemed to be more of an issue than other parts of the state. So they actually developed some communications and campaigns targeted for those specific communities in both Spanish and English. So the specific part of the state where they saw that gestational diabetes was more of a problem based on the data that they were getting out of this project. Next slide. So they have started to see if they can evaluate the results of their media campaign as well from this. They're still working on some of this now, even as we speak. The evaluation piece seems to be a little trickier, but they were definitely able to identify the parts of their population where gestational diabetes was more of an issue. Next slide. So the next S&I framework that I'd like to talk about is clinical decision support as a guidance, as sort of a service. This is moved into part of the clinical quality framework overall S&I initiative, but within that there's still this concept of clinical decision support as a service. So here the idea is sometimes the clinical decision support that you might want to offer an EHR is something that public health actually has better real-time data about that decision support that should be happening. So the EHR could call out as a service to a centralized clinical decision support instead of having that information directly embedded in it. some simple examples here might be screenings. So when are certain screenings appropriate? So you could send a message to a centralized clinical decision support with the demographic information and history of a person and get back information on what types of screenings they have not had and would be recommended. Next slide. So there are some other interesting pilots planned around this. For example, when a communicable disease might be reportable for something like pertussis, or even around immunization forecasting, making that service available to EHRs about what vaccinations are due when. And I think another really interesting example around this that's not listed on the pilot is this concept of public health having better real-time surveillance information. I know as STD treatment is moving out of being directly run by state and local public health clinics, public health has concerns that the private clinics now offering those services might not have the best and most recent current recommendations on treatment information based on antimicrobial resistance profiles in the community. Here's a real example where public health could be keeping up with the surveillance information and offering real-time clinical decision support on the treatment at the point of care. Next slide. So the final S&I initiative that I want to talk about is structured data capture. I think I'm running a little low on time, so I'll try to be a little quick here. Structured data capture is a concept that was introduced because a lot of different domains, including public health, clinical research, FDA, all wanted some additional data elements to be certified as part of a basic electronic health record so it would make their work easier. And the EHR vendors pushed back really hard on this, saying that it was very difficult for them to add these additional data elements and to also keep them updated in a way that met the requirements of their partners. So this concept of structured data capture came about. And I'm going to give you an analogy here of when you purchase something via PayPal on a retailer website. I think that's probably the best analogy to understand what structured data capture is all about. So when you purchase something on a website like eBay, for example, which I tried to do this weekend, but I lost my auction. But when you purchase something on eBay and you click on the PayPal option, a message actually gets sent over to PayPal that says, hey, here's this guy, here's all his information. He just purchased this product with this price, and these are the shipping costs. And PayPal knows how to consume all of that information and pre-populate your PayPal information with all of that data. You don't have to re-input what you purchased and who you purchased it from PayPal. You might enter in then some additional data to confirm your shipping address, or if you're shipping it as a gift that you want it shipped somewhere else. And once you complete all of that information within PayPal and you click submit, that all goes right back to the retailer, and now eBay knows that you've paid and where to ship it to. They don't have to process the credit card payments on your behalf. All they have to do is have that interface between PayPal. So we've set up sort of this same concept with structured data capture between electronic health records and what we're calling forms managers, or to keep track of the additional information that agencies like public health might want to collect. So I'm going to use STDs as an example here again. So let's say that a physician wanted to report a case of gonorrhea, and they did not want to fill out the paper case report form. So they could actually click a button within their EHR, or maybe their EHR even knows through clinical decision support as a service that this is reportable. And it pulls all of the basic demographic information, all of the data that's in an EHR, and sends it over to the forms manager and says, hey, I've got to fill out the gonorrhea case report form. What are the questions that I need to ask? Here's what I have already. So that forms manager can take all of the data within the EHR and pre-populate it into a form with all the information about the tests that were done, the patient information, the demographics. But then there might be some additional questions that aren't clearly available within the EHR. And for an STD, the things that aren't extractable information from the EHR include critical information like pregnancy status and treatment status. So those two fields could be displayed back in the EHR. And again, this is kind of like the PayPal model. And in PayPal, it's never like you really left eBay. It's all the same web experience. So here within the EHR, a form gets pre-populated, presented to the physician with everything already filled out that they can confirm or change if they want, but also a couple of additional data elements that might not be in the EHR, like treatment status and pregnancy status. Or let's say if it was a measles case and you knew of an outbreak going on and you wanted to ask, have they been at Disney World in the last 2 weeks? You could add that question on the fly on the forms manager side, and the EHRs don't have to do anything to pull in the most recent questions that public health would like to ask about that particular condition. And then once that information gets populated within the EHR, it can then get sent directly to the requester, in our case public health. So structured data capture defines all of these sets of standards and interactions for how that would happen. And if you remember, case reporting was something that I had listed in the notice of proposed rulemaking, and this standard for structured data capture is actually the standard that's referenced for that. Next slide. I'm going to skip this slide and go on because I want to talk a couple of seconds about, can we just skip to the end, or skip, I'm not going to talk about these, skip, we can answer questions with those. Yeah, thank you. I want to talk about the platform. So the public health community platform is actually building some of the infrastructure to support some of this, especially the electronic case reporting. So the public health community platform is a project with ASTHO with funding from the CDC to build a set of services to support things like electronic case reporting. Next slide. So the idea here is that they're working with a set of organizations including CSTE, ISDS, NACHO, APHL to host some services in the cloud with Amazon Web Services to support things like electronic case reporting so that every single health jurisdiction does not have to rebuild all of that functionality on their own. Next slide. And so here's just sort of a schema of how they're thinking about doing that is thinking about the different types of tools and services that are needed and putting them all together in the cloud so that they can be reused in different ways. And you'll see case reporting is there as one of the potential services that they're building. Next slide. And here's just sort of an architecture of how we think we might be doing that on the Amazon cloud with ASTHO for case reporting, where an EHR has some trigger codes where they might know something should be reported. They could ask a decision support service on the public health side, is it really reportable, and then get back the form to report it and then submit it. So it's a very interesting architecture here that actually includes both the clinical decision support as a service as well as a structured data capture for capturing information. And I think that's hopefully my last slide. I'm going to go on to the next one. Yeah, so yeah, that was my last slide. Thanks. Okay, I went a little over, sorry.
No, that's great. Thank you, Jim, so much. That was a pretty amazing tour of the world of HIT as it applies to public health. So thank you for sharing that perspective, which is what you do so well, coming from state public health and then at the federal level, not only working with the necessary proposed regulations and the like, but also really integrating it to very practical and very timely public health applications. So we we will take a minute. Let's just take a couple minutes right now. If anyone has a burning question, I don't see any that have been posted in the chat box at this time. But if anyone would like to ask a question of Jim now before we move on to Joe, we would ask our operator, Shay, to maybe remind us how to do that, how to do an audio call, and I'll proceed with any calls that may be in the queue. Shay?
At this time, if you have a question, please press star followed by 1 on your telephone keypad. You may also enter questions at any time throughout the webinar by using the chat feature located in the lower left corner of your screen. Again, to ask an audio question, press star followed by 1 on your telephone keypad. We'll pause for just a moment. And your first question comes from the line of Bryant Cummins. Bryant, your line is open.
Hi, Jim. This is Bryant. I'm going to ask a question that I've asked you many times before and asked folks from both New York and Massachusetts. One of the projects you described, the query health model, is that something that you think is reproducible at other state and local health jurisdictions that don't have the benefit of a Harvard or a well-funded public health institution?
That's a great question, Brian. And I think with the right standards work and the support of the public health community platform, that yes, I think that is something that could happen for multiple public health jurisdictions. I think one of the first things that would have to happen is that we really take what we've learned from Massachusetts and New York City and develop a public health specific data access framework implementation guide. So that is activity that I would love to see someone from the public health community step up to and be the owner of, just like we've had people step up and be the owner of getting electronic case reporting implementation guides done. And I know that's where a lot of focus is right now, is around the electronic case reporting, but I think to make the same sort of strides in this world, we need people to step up and really help define those standards. Because if we had those standards that we could share with the vendors, then I think it is reproducible. A lot of the work, as you said, was done by very competent individuals and contractors who did a lot of one-off work with the providers and the vendors to make this happen. But if we had a set of standards for that, I don't think it would be as difficult.
Thank you.
Again, that's star 1 to ask a question. Star 1.
I'll go ahead and pose a question to you, Jim, that has appeared in the chat box. And then if there are more questions, we'll hold them until after Joe's presentation. But Jim, a question came in from Virginia Dado, and the question reads like this. How would the confidentiality of questions such as, did you go to Disneyland, or who did you have sex with, how would those questions, how would the confidentiality be handled? Would answers be kept confidential and out of the patient's EHR after sending them to the health department?
So I think that's a great question, and depending on the actual questions, the EHR may want to keep a copy of that as well. And I think some of those questions would involve working with them to figure out exactly what is sent over versus what they might want to keep a copy of. And then I think the other part of that question that is implied is if the public health community platform is facilitating the transfer of that information to the appropriate health department, are there issues with the storage of that data there as well? And I think both of those are things that can be addressed with the appropriate business associate agreements, and also making sure that wherever possible from a technical solution, the data is not stored at places where it doesn't need to be. And I think there are ways to architect this and ways where data is just moved across to the appropriate receiver without being persisted at a place like the EHR or the cloud. Those are some of the things that we are going to be working out, hopefully in a pilot that should be starting soon for some case reporting activities.
Great, thanks, Jim. And Joe, if you'll bear with us for one more minute, there's one more question that I don't want to get lost before we turn to Joe's presentation. This is a question to you, Jim, in connection with the community platform. Kelly Robinson asks, will the platform be funded by ASTHO to be something health departments can buy into? And I'm not sure that you are prepared to address that, Jim, but I'm certainly interested in any comments.
Sure. So I'm guessing Paula is probably not on the call, because if she were, I would ask her to answer that. But I will say that the folks working on this on the ASTHO side, which is led by Paula Soper, who's an amazing leader for this project, they're exploring multiple ways that it could be sustainable. And public health department buy-in is certainly one of the options. I think for these initial go-around, CDC is funding much of the work while the concept is proven, but the sustainability model is still something where there are lots of options being thought of for how this could continue to be supported. And I know a lot of the folks on this call are SIM states, and I think figuring out how we tie these activities into SIM activities is a critical part of sustainability moving forward.
Well, great. Thanks so much, Jim, for all of that. And there'll probably be some more questions at the conclusion of the discussion. But let's move to Joe, Joe Foxhood in Louisiana. And Joe, we've got your slides keyed up here for you, so we'll turn it over to you, Joe.
Alrighty, good afternoon or morning, depending where you are. Just a word of who we are, Center for Population Health Informatics. We were first formed in September of 2014, so we're pretty new. We drew together in one place, though, a number of cross-cutting OPH-wide efforts, such as meaningful use. We have collected inpatient data for a while. We're trying to do more population-wide health and analytics and visualization of our data, including Medicaid data and chronic disease. We're working on community and state health assessments, and we are trying to bring in all the social determinants of health and making them a part of our visualizations. And we're also being a resource for all of the OPH epidemiology and statistics staff. Let's see if I can make this go. It worked. So I've been asked to share my state's experience with public health collaboration and Medicaid and an outside entity, and how we've made that mutually beneficial for all parties. Under the Department of Health and Hospitals, DHH, we have the Office of Public Health, and we also have Medicaid. And then we have the Louisiana Healthcare Quality Forum. I'm going to use these abbreviations a lot, or the Forum. And that is a nonprofit dedicated to healthcare reform and HIT. The Forum manages our state HIE, and therefore this had an ongoing relationship with DHH for quite some time. The Forum was our designated entity during affordable care funding, and now they're nonprofit. Also, I wanted to remind that in Louisiana we have privatized Medicaid. So we have currently 5 managed care organizations, MCOs, that we work closely with through Medicaid as the lead entity. So these are some of the collaborations we have between DHH and the Forum as of today. For the participants in the HIE, the Forum is the agent that sends us the public health reporting for immunizations, syndromic, and ELR. The bidirectional isn't quite there yet for VFC, but the rest are all there. There are REC. The health promotions team is basically chronic disease and public health. So they do a number of efforts for that group as well. And Medicaid is working with us to develop an ED registry, and that would be for the MCOs or for Medicaid only, to try to get a handle on avoidable visits for their patient care coordinators at the MCOs. Our latest collaboration between particularly OPH and the Forum is the Electronic Health Records Project that is putting certified technology in all 70 plus of our clinics that we run in the state. Those clinics have a very limited array of services, including things like STD treatment, testing, TB treatment, WIC, child special health services, reproductive health, stuff like that. So to talk a little bit about our EHR and what that's doing for us, we had for a long time a variety of applications that didn't talk. Each unit had to communicate with it individually. None of them was a proper health record. The closest we came is logging the encounters in the billing system. All the charts are paper-based. There's no exchange between the units. Billing was done by an outside vendor, and we have no practice management ability. So we couldn't really even achieve meaningful use reporting to ourselves from our parish health units to public health. So the way public health operated is we would dial into the lab system and into the billing system and extract data elements of interest for surveillance purposes. But obviously that's not the best way to do it. So just by changing our architecture, which is now up and running in the entire state, has been for nearly a month as of tomorrow. Just changing that architecture to a cloud-based system allows meaningful use compliant transactions between the EHR, between the lab. We have our own state lab, and on the public health offices. The EHR is also going to be part of the Health Information Exchange. We call it here LAHI. We can also now monitor the meaningful use objectives for the clinicians in the health units. Since most of our patients for the services we provide are Medicaid eligible, it made sense for us to go after the available incentives. So I borrowed this slide from elsewhere, but it's pretty standard. These are the goals that we anticipate the health record to achieve for us. They include patient care improvement, data interoperability, the healthcare costs, both within the parish health units and external providers sharing data, because there's no ability to do that whatsoever right now. And then as far as reducing health disparities, we'll have a much better way to analyze our data in a more population health-wide sort of way. So in order to even begin our collaboration, we took this foundational step of creating a data sharing agreement. So even though Medicaid and Office of Public Health are both under GHH, we still had some of the same problems that states or jurisdictions that have a different Medicaid office entirely have with sharing, with pulling down some walls and sharing data and collaborating. So we did this data sharing agreement. That is the purpose right out of it. And then these are the sections that we put in it, and they're all pretty fully featured. It does talk about expediting the data sharing and file exchange. It used to be a very onerous process. Specific data requests have sped up a whole lot. We get a lot of chronic disease data out of there for lack of having a more comprehensive source, but we have such a high percentage of persons on Medicaid that it's actually very representative. And then flowing back to the Medicaid data folk are the Parish Health Clinic data and program data that helps the managed care organizations calculate their HEDIS measures. So in order to achieve the reimbursement rate that they're hoping for, they have to prove that they've achieved certain goals, and they don't necessarily have any data but their own to do it with, so we help them with that. So for using Medicaid claims, this has helped Office of Public Health. These are some examples of that. We did some studies with elective delivery. We did ADHD overprescription of medications. Diabetes rates, of course, are a problem, especially here, especially in the South. We do a lot of our 1305 grant data by using Medicaid data and other sources. We are verifying our Ryan White enrollees to make sure that they don't have Medicaid first. And then the Title V, Title IX reproductive health. We are able to get a lot of data out of those for those out of Medicaid as well. Also, having the data sharing agreement has given us actual people to talk to instead of just a data request form. so we can ring them up and expedite our requests. And then conversely, we have helped Medicaid for some of the HEDIS measures, as I was starting to say earlier. Louisiana has put into place these measures that have reimbursement rates attached to them, incentives and or penalties for meeting the clinical quality measures for health screenings and medication compliance. So we're using the data that we can access to supplement what the plans already have in place to help them meet the measures. One of the measures that might be interesting is the HIV Viral Load Suppression measure. So using the baseline of Medicaid enrolled patients with an HIV diagnosis, we match to our HIV surveillance system and return a flag that merely says suppressed or not suppressed to the plan itself. We've also collaborated on multiple GIS projects, including sharing funding for the software and tools that we use. And then here are some joint ventures that we have done together. We work on the IAPD together so that we can coordinate our activities. The person who is in charge of installing the EHR is supported through Medicaid. I spoke earlier about the ED registry to try to get a handle on unnecessary visits to the ED for Medicaid patients specifically, and the way we're doing that is through a parallel feed that resembles the syndromic feed, so it's not very much of a burden on any of the facilities. We are using technology available on both sides to accomplish our goal. So the ED registry has two possible points of entry. You can report directly through the HIE, or like I said, as feed alongside the syndromic feed to OPH, and then we'll share it with the HIE. So the cooperative endeavor agreement with the forum contains activities for both Medicaid and OPH. That's our internal document that helps us fund the IAPD activities. And then we have a biweekly status meeting with the Medicaid and OPH and the Quality Forum, where we all prioritize and monitor our projects together that we hope the forum will accomplish for us. So the data sharing agreement was the part that took the longest. Like all public health, or most everywhere public health, the various programs under OPH are responsible for their own data sets. So every program in OPH that had a data set mentioned in the DSA, the data sharing agreement, we involved staff representing the program's needs and concerns. It was a long process, but it was very worthwhile because all programs then bought into the concept, especially those with particularly sensitive data such as HIV. I think the most interesting thing for me was that just getting used to the idea has taken time. So we're used to having put in lots of forms and requests and getting layers of signatures, and those things all went away. And so it's taken some time to wrap our heads around much quicker access to the data that we need. We also added just this year, in 2015, we've added the Office of Behavioral Health. We haven't done much actual data sharing with them yet, but it was a similar process, and we look forward to a lot of collaboration with them as well. So the challenges we faced: the Health Information Exchange presently claims 239 participants, but not all of them are on board to report data to public health just yet. It's a federated model, so the data do not live in the HIE. It's merely exchanged through them. So the public health reporting is sort of a on-the-side feed. It doesn't use the clinical data at this point. The Greater New Orleans HIE, or GNL HIE, is one of the other big players in the state. And then there are some large hospital networks and private HIE providers. There's a lot of competition going on. And I think in Louisiana, one of the things that I'd like to see happen is that they are encouraged to exchange data between them. Right now, they're all fighting for market share, and that's keeping them from being any sort of comprehensive source for data. We started receiving our inpatient discharge data in 2009. This year, legislation added the ED and ambulatory care data into the same data set. So we have to promulgate a rule, and then we should be able to receive those data as well. This was all done through legislation designed at increasing transparency and consumer right to know. We use the data partly to create a website where people can compare costs for the top most used procedures between facilities. And so once we add the ED and the ambulatory care, that'll be really adding a much fuller picture of what's going on in the facilities. It'll give us a stronger ability to analyze on a population health basis. Although it's still not entirely all the data we need. So we are looking forward to working on adding all payers' claims into the data set in successive years. Right now we're changing governors and it's not the good time to do that. But it makes it harder to look at the state when you have a smaller data set to do it with. And the other challenge we've had is that the HIE hasn't really let us into the data yet. We're still trying to work out with legal the fact that if the nonprofit has signed agreements, it doesn't necessarily mean public health can't access the data. So we're still working on that one. And lessons learned, even though we had what should have seemed like a luxury of having OPH and Medicaid both under the same roof, there were just as many walls historically as if they were separate departments. But there's still as many opportunities to collaborate on projects that benefit both sides. So for us, starting with the data sharing agreement led to other collaborations because barriers to sharing came down. Because of the ties between Medicaid and OPH now, we are able to manage our various projects with quality forum together, prioritizing them among us and helping shape the projects in ways that benefit all of our goals instead of just one office. That is me. Feel free to contact me later or if you have any questions now.
Great. Thank you so much, Joe. That was terrific to kind of walk through how your state has developed, and it's clear it's a process, it's an ongoing process, has developed new data sharing agreements and to the positive results of that. I would encourage you, if you have questions now for either Joe or Jim, you feel free, please, to post them in the chat box, or if you would like to pose them via audio, go ahead and do so at this time. So let me read a question that has come in on the chat box, and this is from Dan Lentine. And I'm not sure, Dan, if this is which presenter. This could probably be presented to either presenter that it's directed to. Question reads, I may have missed this. What was the impetus for getting the forum together? Was there a mini grant, or how was the energy galvanized to get this done? And that, yeah, Dan suggests that Joe, that one be directed to you.
Sure. This slightly precedes me, so I may have a detail or two off, but as I understand it, when the Affordable Care Act dollars came over for HIT work, the state decided that it would rather have a nonprofit do it or an outside entity. So it made the forum the state designated entity. That designation ended when the funding did, and now it's not just a nonprofit, but as a result we have a long-standing arrangement with them.
Got it. Thank you. Operator, are there any questions in the queue?
Again, *1 to ask a question. There are no audio questions.
Thank you, Operator. I would like to ask a few of the questions that have been submitted in advance then to both of our speakers. And feel free to add from your perspective what might be helpful in terms of a response. The first question has to do with the recent HIV outbreak in Indiana that was associated with injectable drug use. The question is, can HIE data be monitored in near real time for earlier outbreak detection?
I'll take a go at it. I would have a different perspective than Jim, but in Louisiana, for example, the theory would be yes. The reality would be we don't have the infrastructure to do it just yet. In jurisdictions where there's only one HIE, I think it would be a lot easier because it would make those triggers that Jim was explaining earlier much more possible and much more real time. If you In Louisiana, for example, we would use ELR data because we process our data and it would be in the surveillance system within 24 hours. But when you need additional information, you would still need to ring up the facility via phone or send a field epi over there or something like that.
Yeah, and I think I'd have a similar answer that I think HIEs can certainly facilitate this and help make it go faster in certain cases, but still the public health has to be there ready on the receiving side and be able to do some of the analytics, and also make sure that all of the right policy and technical agreements are in place with the HIE.
I think a plus for the platform's idea of setting up triggers would be that you could monitor for other things besides an HIV diagnosis. So you could measure, or you could trigger on any sort of diagnosis that would indicate that injection drug had been used, and then you could send folks to follow up and make sure that there was HIV testing done as a result.
Yeah, that's a really good point, and I think certainly there are multiple use cases for how some of that infrastructure could be put to use.
Great. Well, thank you. We do have a chat box question from Cassandra Codes Johnson, who says this question is for Joseph. Did all the collaborative partners share the costs related to launching and maintaining the EHR? Who is paying for this? Question.
Okay, so we were allowed to use some 90-10 match for the initial infrastructure. As far as maintaining it, we are relying on being able to achieve the incentives, and also the cost for running the parish health units has been borne typically by the parish health unit, or by the Office of Public Health, by a branch of that. We do try to self-fund as much as we can, obviously through Medicaid reimbursements and other private insurance, and a great deal of what we do is federally funded, which I think was how we got to the array of services we offer in the first place. So it's primarily public health being responsible for the parish health unit funding, but there are some collaborations because it's Medicaid patients.
Thank you. Operator, I'm assuming you don't have any calls in the queue, and if that's the case, I'll pose another question that was submitted previously.
There are no audio questions. Again, that's *1 to ask a question, though, but there are no audio questions at this time.
Thank you. So here's a question for both of you that's kind of far-ranging. It reads, given all the health data breaches and heightened sensitivity around privacy, do you foresee any sort of consumer backlash to sharing of health information technology or, quote, big data type analyses?
I think there certainly could be. I think a lot of the kinds of information that we're talking about are already in laws and regulations at the state level. So I'm not sure what the result of that would be, but I think that always is certainly a potential.
I guess when I was trying to think of a response to this one, I thought too, knock on wood, we've always been very concerned about our patient privacy, so we have a very heightened sense, I think. And I was also thinking that when we were talking about some HIV-specific kinds of questions, HIV data has been of the highest security for years and years. And what I think has happened over the years is that the rest of public health data has come up to its standard rather than us relaxing about HIV, which I think is a good thing. So what I also think is as we partner with other outside entities, we have to remain the subject matter experts on privacy and security and make sure that all of our partners are just as up to speed as we are and compliant and following all the same rules.
That's really a terrific observation. Thank you.
We do have a question from the line of Bryant Thomas. Bryant, your line is open.
Hi, Joseph. This is Bryant, Washington State. I'm curious, the organization you described of forming an Office of Population Health, the center, it sounds like you tried to pull in expertise from throughout the agency in terms of the data sets and the contributions. Did you pull in actual staff, epidemiologists from those units and bring them under this umbrella of the Office of Population Health, or did those folks stay in place and you act more as a virtual organization?
I guess I'll be really honest and say the folks that we brought in were kind of all orphans, so we didn't like rob any existing program areas. Some of them came from the Office of the Secretary of DHH. Some of them came from IT, and there was nowhere else to put them. But by the same token, they did things that were like core to all of OPH and not any specific program. So those folks are actually ours. Literally ours. What we also do is have periodic EPI gatherings where we pull together EPIs that do belong to specific programs and are particularly aware of the data in there. And we share our tools and we share the kinds of data we have and figure out ways to collaborate that nobody knew we could do before. So we have a little bit of both. We have contact with the EPIs that are all over the place, and we try to coordinate them, and we try to share what we see as opportunities to expand what we all know, and then we also have our own little group.
Thank you.
Thank you, Joe, and thank you, Bryant, for that question, which is very much a reality-based question. I understand that epidemiologists in large organizations are not entirely fungible. That's not the right word, but that it's very difficult to build a cadre across an organization. So kudos to you, Joe, for pulling that together. Other questions? Operator?
There are no more audio questions.
Okay. Well, I don't see any more questions in the chat box. There's one more question that I'd like to pose to both of you that has to do with, I think you both mentioned the evolving scope of the practitioners, the clinicians that are either working towards meaningful use or actively engaging with health information exchanges. As we look more and more, you can see I'm not reading this question. I'm embellishing it a bit, but with the advent of accountable care organizations for instance, for those with chronic disorders, integrating both primary care as well as specialties, as well as behavioral health, as well as even oral health and dental care to improve outcomes is more and more becoming piloted, at least in terms of delivery. So can you both talk about the prospects that you see in the future for bringing in other types of providers, particularly I guess behavioral health are the ones that are of most interest at this point?
Yeah, this is Jim. I think that's a policy issue that is actually slightly above my pay grade. I tend to focus just on the things with public health. I know that we're working on, from an ONC perspective, just how to work with other providers who aren't currently incentivized, but bringing them into the incentive payment program is really a CMS issue more than an ONC issue. But from a standards and development strategy, ONC is definitely reaching out to those types of providers and trying to figure out the best ways to work with them.
Great.
And
gee, I'm also kind of like not sure what to add other than here in our state we are starting to move forward with behavioral health. We are understanding that to understand a population health picture, you have to take in all of the health conditions, including behavioral. Also in our community health assessments, we've conducted one round so far through the state in April and May, and mental health issues came to the top of everyone's list of most important health conditions. So we're struggling with, again, the same thing everybody else is. How do we draw them in? They are a completely separate program, and they have been very, very siloed in their data as everywhere. So how do we collaborate? Because we all know that each other's world of experience affects the other programs. Physical health affects mental health just as much as the other way around. So we're struggling with that too, and there aren't incentives right now, and there aren't extra funds right now that we know of. So yeah, I guess just keeping on talking about it and sharing state experiences is a good thing to do.
Sure, great. Thank you very much. I would just like to add a point that was made by one of our participants, not really a question, but I think it applies as we're wrapping up the conversation. And it was made earlier by Veronica Graham, who noted, I'm a public health professional and student. I knew about HIT and EHR, but having this tour was amazing. Thank you for the insight. So I think that applies certainly to both of our presenters. So with that, I'm not seeing any other questions. I would like to remind everyone that the slides for today's webinar will be posted in the next week to, you see it on the slide there on your screen, at ASTHO's website. And so go ahead and take a look at those. And please, we're going to ask you, as you can see, to take a few minutes as we finalize our discussion today. Take a few minutes to complete the survey, the link you'll see there, which really does provide us with useful information for future projects. I want to take this minute and to heartily thank our two presenters who've gone through an amazing amount of information here and shared with us. And also, I want to thank CDC, the Centers for Disease Control and Prevention, for sponsoring this webinar. This is the last, as I mentioned, of a 4-part technical assistance series. And throughout it all, our speakers have been absolutely informative, and their presentations have been extremely valuable for all the participants. A recording of today's webinar will be available on ASTHO's website along with the slides in the next few days. So we hope that you'll use this webinar as a resource and share the link with others once it becomes available. So with that, again, I would like to thank our presenters very, very much for your terrific work in making HIT accessible and exciting to us. And thank you all for participating. Enjoy the rest of your day.